Good afternoon, everyone, and welcome to this webinar. Could you please indicate in the chat box if you could hear me okay? Great. Thank you so much for attending. So let's go ahead and get started in the interest of time. Welcome to this Nclex review series. Some of you have attended last week's presentations, and for those of you who are attending for the first time, I want to welcome you. This is a series of review sessions to prepare you for the Nclex. My name is Dr. Tom Madayak. I'm a faculty at the BSN RN to BSN program at Broward College, and my interest in Nclex has been for a long time, since 1996 to be exact. So anyway, I used to be the coordinator for the Nclex review series of people who failed the Nclex at Miami-Dade College way back when, several years ago. But anyway, welcome to this webinar. And now we're going to start with our topic for today, which is on sepsis and ARDS. So let's begin with sepsis. Sepsis is a life-threatening organ dysfunction. And when we talk about sepsis, we refer to septic shock, which is actually a medical emergency. And this is going to be characterized by severe systemic responses to infection. And because of this response to infection, there's going to be a drop in blood pressure and tissue perfusion, and therefore impairment of organ function. So septic shock, as I said, is an overwhelming response to an infection, and it results in a systemic inflammatory response. So what causes septic shock? Well, septic shock is typically triggered by bacterial infections, but viral as well as fungal infections can also lead to it. And the most common sources of infection are going to be your pneumonia, your urinary tract infection, and abdominal infections. So it usually is caused by bacteria, but viruses as well as fungal infections can also be the precipitants as far as the infection is concerned. The most common are going to be your E. coli, as well as Staph aureus, as well as Streptococcus. So the pathophysiology behind septic shock begins with the release of inflammatory mediators. And when I say mediators, these are substances that are released by the body whenever there is an infection. And because of these inflammatory mediators, there's going to be vasodilation. So the blood vessels are going to be very dilated, and that is the reason why there's going to be a decrease in blood pressure. As a result of this vasodilation, there's also going to be an increase in capillary permeability, and therefore this leads to organ damage as well as dysfunction. So whenever we're talking about sepsis, one of the complications of sepsis is ARDS. And that's exactly why I begin this presentation with sepsis first, so that you understand how it relates to ARDS. But there are some important parts of the sepsis bundle that we need to review. So if we remember, bundles are tools that healthcare organizations use to implement evidence-based guidelines, and they have been recognized to improve outcomes in the treatment of sepsis and septic shock. So what are some of the most important things that are going to have to be undertaken whenever a patient is suspected of having sepsis? Let's begin with the first hour. The first hour interventions are going to include measuring the lactate level. The value of measuring lactate in patients with sepsis is because of the fact that it provides useful information about the progression of the condition and the effectiveness of the treatment. So we begin by asking, what is lactate? Well, lactate is a chemical naturally produced by the body, and this is to fuel cells during times of stress. When it is present in elevated quantities, it is commonly associated with sepsis and severe inflammatory response syndrome. So normally, when you have normal levels, lactate is between 1 to 1.5 milliosmoles per liter. Let me just write that down. So normal is usually 1 to 1.5 milliosmoles per liter. That's the normal. So, however, in critically ill patients suffering from shock or hypoperfusion, lactate is often elevated to 2 milliosmoles per liter. And so this is the hallmark for the diagnosis of the presence of sepsis. So when we have a blood level of lactate of over 2 milliosmoles per liter, then that means to say that the patient is having insufficient oxygen supply into the tissues, and therefore the lactate levels reflects the presence of septic shock. Now, anytime you have a result of a lactate level above 2, part of the bundle requires you to always remeasure the lactate level to be sure that this laboratory finding is really accurate. Now, in addition to that, whenever you identify a lactate level of more than 4 milliosmoles per liter, this is going to be a sign that this is an emergency. That means to say that anytime you have a lactate level of 4 milliosmoles or more, it indicates the need for immediate resuscitation and admission to the ICU. This is usually a bad sign. It is associated with a high mortality rate. And that is why if you are in the medical surgical area or in any other areas other than critical care, whenever you have a result of a lactate level of more than 4, this is the time for you to activate the rapid response team in order to draw the experts in the resuscitation of this patient. Okay, so I said 3 different important things at the moment. Number 1, that the lactate level of 2 or more is a manifestation that there is going to be insufficient oxygen supply in tissues and therefore reflects the presence of septic shock. Number 2, that in the event that the lactate level is over 4 milliosmoles per liter, this is a medical emergency, and the rapid response team has got to be activated. And number 3, that whenever we have a patient with septic shock, there's got to be initiation of therapeutic interventions as soon as possible. And those interventions will include fluid resuscitation. So going back to this particular slide now, the things that we need to complete within 3 hours are the following: measuring the lactate level, obtaining blood cultures prior to the administration of antibiotics, administration of broad-spectrum antibiotics, and to administer 30 mL per kilogram of crystalloids for hypotension or any time the patient's serum lactate levels are going to be 4 or more. milliosmoles per liter. And as you could see, whenever we have sepsis, these interventions have got to be continued, and the 6-hour mark are going to include the following: that in the event that the fluid resuscitation does not respond, the shock does not respond to fluid resuscitation, then vasopressors such as norepinephrine could now be undertaken in order to maintain a mean arterial pressure of over 65 millimeters of mercury. And in the event of persistent hypotension, then there's got to be other ways for us to be able to evaluate the effectiveness of fluid resuscitation. So how do we evaluate the effectiveness of fluid resuscitation? It's not only through blood pressure readings, but actually through CVP evaluation as well, or central venous pressure. And I'll be talking more about this in a little bit. And lastly, to remeasure the lactate levels, again, anytime that you're going to have a lactate level of 2 millimeters or more, milliosmoles or more. So let me go back to the measurement of mean arterial pressure. And the reason we go back to mean arterial pressure is that oftentimes when we're looking at a patient, and we're looking at a patient, let's say, that has a blood pressure of 90/60, we really are not sure if this blood pressure is going to be good or sufficient enough. And thus, it is imperative that we switch into monitoring the mean arterial pressure. So, what is the mean arterial pressure? Mean arterial pressure is obtained by getting the systolic blood pressure and adding the diastolic pressure times 2. So we multiply the diastolic blood pressure times 2, and we divide it by 3. Okay. So supposing now that you are monitoring a patient or have a patient that has a blood pressure of 83/50. So is this patient perfusing well? Well, we're going to find out, because we say that perfusion occurs when the mean arterial pressure is supposed to be over 65, right? Okay, so in this particular instance, we take 83 plus twice the diastolic blood pressure, which is 50, over 3. And then we now add 83 plus 100 divided by 3. So 183 over 3 is equal to the mean arterial pressure. And this happens to be 61 millimeters of mercury. As you could see, this blood pressure or mean arterial pressure is insufficient to supply the body with enough blood. So let me just find out if you understood that. So let's say that you have a blood pressure of 90/60. Would you calculate the mean arterial pressure of this blood pressure? Okay, what was your what is your answer? 70. So that means to say is that it's sufficient blood pressure or mean arterial pressure. And the answer to that is yes, it is a sufficient mean arterial pressure. So that is exactly the importance of calculating the mean arterial pressure in order to determine that tissue perfusion is occurring. So that's all we're going to talk about septic shock. And this gives us now a good knowledge to understand what is happening in ARDS. Why is it that ARDS is a complication of septic shock? Okay, so let's begin our discussion with ARDS. What is ARDS? Well, it stands for Acute Respiratory Distress Syndrome. This is a life-threatening lung injury. And what happens is that there's going to be leakage of fluid into the lungs. Now, this has a high mortality rate, with severe cases having the poorest outcomes. And usually it occurs in people who are critically ill or who have significant injuries. So to lay the foundation of the understanding of what happens as far as the pathophysiology of ARDS, we need to go to a discussion of the alveoli capillary network. So think about the respiratory system and think about the alveoli. Whenever we talk about the alveoli, we have a lot of them. An average person has close to 500 million of alveoli in the lungs. And each of these is responsible for performing two critical tasks. And the first task is going to be to transport oxygen into the tissues. And of course, the second task is going to eliminate or excrete carbon dioxide. All right, so how do they do this function? How do they achieve this particular function? Well, whenever you breathe in and you're going to have your airflow coming in, obviously the air that you breathe is going to be rich in oxygen. And because the pressures of oxygen are higher in this area, through diffusion, they now go into the capillary network, which could then be circulated to all parts of the body. The pressures of carbon dioxide are going to be higher on the venous side, and therefore this is going to go to an area of lesser concentration, and therefore it's going to be eliminated. So notice that the diffusion of oxygen and carbon dioxide is going to be possible as a result of the presence of specialized cells called type 1 epithelial linings, which allows for the oxygen and the carbon dioxide to pass through. So this is one type of epithelial lining in the lungs that would allow for this exchange to occur. Now, the other thing that is going to be important in the anatomy and physiology of the alveoli is that there is another type of cells, and this type of cells are type 2 epithelial cells. And this type 2 epithelial cells produces surfactant. And again, surfactant is an important secretion. This is an oily secretion that coats the alveoli and prevents their collapse. All right, so let's talk further about this type 2 cells and their function of producing surfactant. Now, when we breathe, obviously, when we inhale, the alveoli expands. When we exhale, the alveoli partially deflates. Contrary to what people think, some people think that when you exhale, that it totally deflates like this, and that is not so. And the reason why it does not deflate totally is because of the presence of these cells which coat this particular lining with the oily substance called the surfactant. That's number one. The other reason, and a very important reason actually, that these alveoli remain open is because of the presence of nitrogen. So if you remember the atmosphere, we breathe 78% nitrogen, 20.88 or 21% of oxygen, and 1% other gases. Now, why do you think that there is a lot of nitrogen in the atmosphere in order to support our life and function? Well, one such important function of nitrogen in the atmosphere is to keep this alveoli open. Okay? So why did God create this alveoli? To deflate partially and not go here to total deflation. The reason why that is because the longer the alveoli is open, the more opportunities for oxygen and carbon dioxide to exchange. Okay, so I hope that you understand that concept, that nitrogen is going to allow for the alveoli to remain open despite the fact that a person has exhaled. And the purpose for that is so that there's going to be longer opportunities for oxygen and carbon dioxide to exchange. So it also underscores why we do not want to give too much oxygen to patients. So let's say that you have a patient over here who is in respiratory distress, and you give him 100% oxygen. What is going to happen? So let's take a look at what happens to the alveoli. The nitrogen was here, which was 78%, but now you're giving a 100% oxygen. What would happen to the nitrogen? If you give 100% of oxygen to the patient, what would happen to the nitrogen that is in the alveoli? Hello? What do you think will happen to the nitrogen that is going to be in the alveoli? Can you hear me okay? All right. Yes. So actually, the nitrogen will be washed off. And so this is what is known as nitrogen wash off, meaning to say that you're going to displace the nitrogen. So if you do not have any more nitrogen in the alveoli, so if this is the alveoli and the nitrogen has gotten out of the respiratory system, what will happen to the alveoli? What will happen to the alveoli? The alveoli will collapse. Okay, so there's going to be a collapse of the alveoli, and thus this is going to result in poor oxygenation. Okay, so in patients who have ARDS, the following is going to occur. There's going to be an alveolar capillary injury, which results in increased permeability and influx of fluid to the alveolar space. So again, if this were the alveoli, and now your capillary network, which was supposed to be something like this thin before, But now, because of the inflammation that occurs in septic shock, we now have a capillary network that will be dilated. Now, when you dilate the blood vessels, what's going to happen? Well, what's going to happen is it loses its semi-permeability. So fluid and substances that were supposed to be in the capillary network will now start to leak over here in the interstitial spaces. So when they leak into the interstitial spaces, what's going to happen to the alveoli? The alveoli is going to collapse as a result of this fluid that is now going to be in the interstitial spaces. So that is one of the consequences that's going to happen. There is an influx of fluid to the alveolar space. And again, in addition to that, what's going to happen? You're going to have collapse of your alveoli. All right. So ARDS, or acute respiratory distress syndrome, can be caused by indirect or direct lung injuries. So when we say indirect or direct lung injuries, we're talking about the direct or indirect injuries to the lungs itself. So indirect injuries are those that occur elsewhere in the body other than the lungs. And direct lung injuries are those that occur within the lung parenchyma and lung itself. So your direct lung injuries would include your pneumonia, your aspiration, your inhalation, trauma, near drowning, and fat embolism. They're all going to be within the lungs. And indirect lung injuries would include your sepsis. It could include severe trauma to the body, massive blood transfusions, pancreatitis, cardiopulmonary bypass, as well as drug overdose. Now, of these causes, the two that are on the top are the most common. So the pulmonary cause of ARDS is pneumonia, and sepsis being the most common of the direct and indirect causes of ARDS. Now, some of you might be wondering, what is the relationship of massive blood transfusions in contributing to the development of acute respiratory distress syndrome? Well, the mechanisms are going to be very complex, and this includes a condition known as TRALI, and this TRALI right over here stands for transfusion related acute lung injury. Okay, so whenever we have a lot of transfusions, what's going to happen is that these substances or this plasma or platelets, they contain antibodies that might react with the recipient's white blood cells or pulmonary endothelium. And this reaction can lead to inflammation and again increase permeability of the lung blood vessels, resulting in fluid accumulation in the alveoli. So it is a known risk factor for the development of ARDS. Okay, so those are the causes of ARDS, both direct as well as indirect lung injuries. And now let's take a look at the symptoms of ARDS. The first symptoms of ARDS usually develops within a few hours to a week after a lung injury. In the very early phases, uh, the, the symptoms are going to be very hard to detect. At first, the fluid is going to leak in the interstitium. So the lung sounds may be normal, or sometimes you might hear a random crackle here and there. But there will also be a difficulty of breathing, and in particular, tachypnea is going to be a compensatory mechanism in the early stages of the disease or the disorder. So this rapid breathing or tachypnea is going to be characterized by or accompanied by respiratory alkalosis. So this is interesting because in the early stage of the disorder, there's going to be respiratory alkalosis, but in the late stages, there's going to be respiratory acidosis. So this is a very, very critical element in understanding the stages of ARDS. All right. So what are some of the other late signs of or late symptoms of ARDS? Well, the tachypnea or rapid respiratory rates and a condition known as refractory hypoxemia. What is refractory hypoxemia? Well, refractory hypoxemia is when the patient will maintain a low oxygen level, even though they are receiving high amounts of oxygen. So when a patient is receiving high doses of O2, but still is hypoxemic, this is what is known as refractory hypoxemia. So that's a characteristic of ARDS. Despite the fact that we're giving a lot of oxygen to this patient, their O2 saturation remains low, and therefore this is what is known as refractory hypoxemia. The other thing is that there's going to be mental status changes, obviously, as a result of poor oxygenation. Tachycardia is going to be a compensatory mechanism. And again, as the fluid is now going to push and push on the alveoli. So if this is the alveoli and a lot of fluid is now going to accumulate around it, it's going to make the alveoli less distensible. And therefore, this loss of distensibility is what is known as decrease in lung compliance. So when you cannot inflate the alveoli, you obviously will decrease the oxygen in the patient. So it's almost like you have a balloon and there's an effort by the body to inflate it, but despite the effort of the patient, there's going to be a restriction or there's going to be a force that prevents it from expanding. And this is what is known as a decrease in the lung compliance. Okay, so what are you going to find on physical examination? Well, the things that you're going to find in physical examination is going to be respiratory distress. They usually are going to be very non-specific, but they could include your tachypnea as well as the patient having tachycardia. Now, because some of these patients are going to be septic shock, they might be hypothermic. And of course, if they have pneumonia, they might be febrile. So their temperatures could either be low or it could be high. So fever is not the only manifestation of shock. You could also have hypothermia. And then, of course, hypotension. The mean arterial pressure is going to be low. And again, whenever we are talking about mean arterial pressure, we are talking about organ perfusion. And therefore, it is better to evaluate mean arterial pressure rather than blood pressure on patients that are going to be in shock. So, further, as far as mean arterial pressure is concerned, I wanted to go back again to it. You remember that we want to maintain a mean arterial pressure of 65 or higher. Normal mean arterial pressure is actually 70 to 100 millimeters of mercury. And this is the normal mean arterial pressure. Okay. But the target in septic shock is to maintain a mean arterial pressure of approximately 65 to 75 millimeters of mercury. So the target for resuscitation of this patient is anywhere from 65 to 75 millimeters of mercury. If the mean arterial pressure is low, that means to say that the organs are not getting enough oxygen. And therefore, resuscitation has got to be much more aggressive in order to rectify the situation. All right. So the other things that might happen is peripheral vasoconstriction as well as evidences of vasodilation. Now, why is that? Because in some shocks, there's going to be vasoconstriction. But in septic shock, there's going to be vasodilation. So if they have vasoconstriction, their skin will be cold and clammy. If they're vasodilated, their skin will be warm. All right, so you could have either one of those. And then, of course, bilateral rouse and even manifestations of pulmonary edema can occur. All right, let's go to the first poll. All right, so let's end the poll. And the correct answer here is letter D, vasoconstriction. Vasodilation and not vasoconstriction occurs because of the body's immune response. Okay, let's go to the next one. Okay, so there's 11 of you. You should be answering or participating in the poll. Okay, so let's take a look at this a particular question. A patient is treated for septic shock. Which findings demonstrate treatment is not being successful? Select all that apply. All right, so letter A is a correct response. And the reason why it's a correct response is because this 40 millimeters of mercury is less than the goal of 65 to 75 millimeters of mercury. And thus, this is going to be a manifestation that the resuscitation is not being successful. How about a urinary output of 10 mLs over 2 hours? Well, this is very, very uh, um, negligible, meaning to say it's very less than normal. And the ideal thing is that we should have a urinary output of at least 30 cc's per hour. So this is, in general, the amount that we expect for a normal person to have as a urinary output. Now, the serum lactate of 15 milliosmoles per liter, again, is still very high, which means to say that we still are not oxygenating the tissues. And thus, remember that a serum lactate that is going to be 1 to 1.5 is going to be normal. And anytime that you have 2 and above, this is going to be the evidence that septic shock is present. And then, of course, blood glucose does not have any bearing at all to this resuscitation. However, the CVP is going to be very important. Now, we did not talk about CVP, but a normal CVP should be around 8 to 12 millimeters of mercury. But it could also be actually expressed in centimeters of water. So CVP, as far as centimeters of water, will be 4 to 12 centimeters of water, which is going to be normal. All right, so let me just regress a little bit to talk a little bit about CVP. So this one was correct, this one was correct, this one was correct. So let's go to CVP. What is CVP? CVP, also known as central venous pressure, is actually a measurement of preload. So what do I mean by that? Okay, so this is the right atrium, and this is the vena cava, the mouth of the vena cava. If we measure the pressure over here, this is what is known as the CVP. It reflects the amount of volume of blood that comes into the right atrium. So this is what is known as preload. All right. So if you have a decrease in volume, let's say you have hypovolemia, what happens to your preload? If you have hypovolemia, what happens to your CVP? It decreases. Okay. So you would have a decrease in CVP. And if you have hypervolemia, you therefore will have an increase in CVP. So when we resuscitate patients, it is imperative that we need to find out whether or not we are giving enough or sufficient amounts of fluids. And the only way that we could do that is to monitor the CVP. So therefore, the ideal is to have a CVP of around 8 to 12 millimeters of mercury, or 4 to 12 centimeters of water. So This particular situation then, wherein there is going to be a CBP of less than 2, means to say that we're not giving enough fluid. Okay? All right, let's go to the next question. Okay, so let's take a look at the correct answer. A patient post-op has a temperature of 103.6, pulse rate of 120, blood pressure of 72/42, and high WBC and respiratory rate of 21, which findings indicates is progressing to septic shock. So a blood pressure of 70/34 after the fluid bolus is going to be a manifestation that the patient is going to be progressing to septic shock. So remember that septic shock is characterized by a persistent hypotension. And when I say hypotension, a blood pressure of less than 90 systolic that doesn't respond to IV fluids. And therefore, they would require the administration of drugs that would increase the blood pressure. So letter C is correct. Norepinephrine is needed to maintain a mean arterial pressure of 65 despite fluid resuscitation. So the hierarchy, as far as resuscitation is concerned, is going to be fluids number 1. If fluids are not going to be sufficient, then we need to give preso receptors or things that increases blood pressure, such as norepinephrine. And then, of course, a central venous pressure of CVP of 18 does not show us that the patient is going to be in shock. All right? So a CVP of 18, although high, does not point to the fact that the patient is in shock. All right? So that is the correct answer. Okay, let's go to another question. Oh, okay, so you remember what the function is of the surfactant. We know that surfactant decreases the surface tension in the lungs. It acts as a lubricant, and therefore the sacs are going to stay stable when a person exhales and therefore won't collapse. But if you damage them, then what's going to happen is that you're going to develop atelectasis. So the correct answer here is atelectasis, letter B. Okay? All right. I think we okay. So it's asking us what are the indirect causes of ARDS. So we say that direct causes are those that are caused by the lung damage itself. Indirect causes are those that are peripheral, meaning to say they're outside of the lungs. So the issue arises somewhere outside the lungs. So the correct answer here, therefore, is going to be sepsis, because drowning and aspiration directly damages the lungs. Blood transfusion is going to be another. And of course, pancreatitis is also going to be another indirect cause of ARDS. Okay, so the correct answer here is letter C. The patient's PaO2 remains at 45 millimeters of mercury. Now, do you remember what I said that a hallmark sign and symptom of ARDS is refractory hypoxemia? And this is exactly what's happening over here on this patient. The patient is 100% a non-rebreathing mass, but the PO2 remains at 45 millimeters of mercury. This is what is known as refractory hypoxemia, meaning to say that the oxygen levels are not corresponding to the amount of oxygen that you give. So again, this is the correct answer. Okay? Yes, the patient can be tired and confused because some of you answered that, but this question wants to know what is the hallmark sign that ARDS is developing. Okay? All right, another question. Okay, so I think all of you, well, the four anyway that responded got this correctly. And the correct response is letter D in ARDS. The capillary, alveolar capillary membrane is going to have lost their semi-permeability by increasing it. And so that is the correct response. All right. So, what are some of the diagnostic workups that will be done on patients with suspected or actual ARDS? Well, chest radiograph is going to be very, very important because the classic bilateral lung infiltrates on chest radiography is going to be very evident. As you could see in the chest x-ray, it looks like there's a whiteout. And this is exactly a very classic finding in patients who have ARDS. CT scan of the chest may be required, particularly in pneumothorax cases and also in pleural effusions. Um, the bronchoscopy could also be done. Analysis of the blood gas is going to be very important. And also analysis of the PaO2 FiO2 ratio is going to be important as well. But the more common way that we evaluate that is through the ABG. Bronchoscopy and the labs would include CBC with differential, your complete metabolic profile, as well as magnesium, calcium, and phosphorus, as well as lactate, coagulation panel, and troponin is going to be also included in order to rule out other causes that might precipitate shock. All right. So how do we manage then patients who have ARDS? Well, the management of patients with ARDS are going to include 5Ps. So we're going to remember 5Ps that are the hallmark as far as managing patients with ARDS. And so what are some of the uh, P's that are going to be evident? Well, the first one is, of course, perfusion. We want to make sure that we are going to maintain tissue perfusion. And the other piece we're going to include positioning. That's going to be the next thing that we're going to talk about, as well as protective lung ventilation. Protocol weaning or weaning them from the ventilator as early as possible. And then, of course, preventing complications. So that's 2, 3. So this is number 1. Okay. So let's take a look at perfusion. What is the goal of care for patients who have ARDS? This is to maximize tissue perfusion in the capillary system by increasing oxygen transport between the alveoli and the capillaries. So how do we do this? Well, we do this by increasing fluid volume without overloading the patient. So fluids are going to be given, and we don't want to overload the patient. So we want to make sure that we monitor the CVP, or in some instances, when patients are going to be critical ill, they could be inserted a Swan-Ganz catheter or a pulmonary artery catheter in order to measure the hemodynamics so that we do not overload the patient with fluids. The other thing is that if the patient is going to be unresponsive to the fluid resuscitation, then what is going to be next is going to give drugs that will help increase perfusion. So what are some of the drugs that would increase perfusion? Well, the first one is going to be the use of vasopressors. And these vasopressors, an example of those might be norepinephrine as well as dopamine. And secondly, we could also give inotropic agents. Inotropic agents are those that increases the force of cardiac contraction. So drugs such as dobutamine or Wtrex or milrinone, also known as Primacor, are some of the other agents that we can do. Okay, so again, perfusion with fluids. If the fluids don't work, then we go to vasopressors. If the vasopressors don't work, then we add inotropic agents in order to increase the force of cardiac contraction. Okay, so the second thing is, of course, protecting lung ventilation. And one of the things that we could do before putting them on a ventilator is to connect them to non-invasive ventilation and high-flow nasal cannula. Now, we always try this non-invasive things first because intubation and mechanical ventilation may be associated with an increased incidence of complications. And those complications might include pneumothorax, for example, as well as pneumonia. And so we try these non-invasive measures first. And the first non-invasive measure is going to be the use of a high-flow nasal cannula. So for those of you who haven't seen high-flow nasal cannula, which we use a lot during COVID, this uses a system of a heated humidification and a large bore nasal prong to deliver oxygen. And the amount of oxygen that we deliver is anywhere from 50 to 60 liters per minute. So it's a high amount of oxygen that we are giving to these patients. So this is usually given in conjunction with what is known as a blender, and therefore it allows for the delivery of precise oxygen concentrations. All right. Now, if that doesn't work, then we could go to non-invasive positive pressure ventilation. So what is non-invasive positive pressure ventilation? Well, I always want to liken it to, let's say that you are in a car and the car is going this way and you stick out your head outside of the window. What happens to the air going into your lungs? Well, there's going to be a facilitated entry of air into the lungs because of this extra pressure that's being delivered to you by the movement of the car against the air. Okay, so it's similar to, therefore, a NIPPV or non-invasive positive pressure ventilation, and we call that CPAP and BiPAP. In a CPAP, the patient is going to be assisted as far as breathing and also going to be exhalation. So the pressure is the same during inhalation as well as exhalation. All right, so that's CPAP. It stands for continuous positive air pressure. So the problem with CPAP is that it might cause the patient to have difficulty in exhaling. And so an alternative to that is what is known as BiPAP. So BiPAP stands for bi-level positive air pressure. And so in bi-level, So the pressure on inhalation Okay, so that's the difference between CPAP and BiPAP. Does anybody have a question as far as that is concerned? CPAP and BiPAP.
I
Okay,
have a
so
question.
sure, go ahead.
Yes, I have a question. Like, so when the patient is experiencing ARDS, how usually do they differentiate on what do they give them, either the CPAP or the BiPAP?
Okay, we try everything first, right? We
Okay.
begin with a high flow nasal cannula because that's non-invasive, okay? If that doesn't work, then we go with CPAP, but sometimes patients are going to have difficulty in exhaling. So depends again on an older patient that probably will go ahead with BiPAP instead of CPAP. And the reason is the muscles of respirations are going to be much weaker. So just imagine now that you are you stick out your head outside on the car, and as the pressure is going, the air is coming in, it's easier for you to breathe in, but it's going to be very difficult for you to breathe out because the air is coming against you. And so BiPAP is much better. Okay. So that's how we would do that. If that doesn't work, then we go ahead and intubate the patient and then connect them to a ventilator. So again, the reason why intubation and mechanical ventilation is not going to be the intervention that we would do right away, because whenever you intubate somebody, there's going to be incidents of complications such as barotrauma, which is pneumothorax. Barotrauma means pressure associated with, trauma associated with pressure. And so this would mean your pneumothorax. All right, very good. Thank you for that question. That's a very good question. Please
Thank
always,
you.
yeah, you're welcome. Please always stop me whenever you have a question. I just wanted to make sure that you understood the difference between CPAP and BiPAP, because that's a common Nclex question. Okay, so continuing with protective lung ventilation, there are other things that we would do then once we decide that the patient has got to be intubated and then they're going to be connected to the ventilator. Okay, so there are several things that I would like for you to remember as far as when a patient is intubated, meaning to say that they're going to insert this endotracheal tube to the patient. What are some of the nursing responsibilities? When a patient is intubated, the intervention is that you should always assess and listen to the lungs, and the lungs should have equal breath sounds. If the breath sounds are not equal, then that means to say that the endotracheal tube has not gone into the right place, because if you know, the trachea bifurcates this way, okay? And sometimes the endotracheal tube might go in here, or sometimes it might go in here. It usually is in the right, more commonly. The ideal position is above the carina. This is the carina right here. And therefore, the ideal place of the endotracheal tube should be here. So if you have a patient that's newly intubated, you auscultate over here, you auscultate over here, the lung sounds should be the same. But let's say you hear the lung sounds over here, but there's no lung sound over here. That means to say that the tube has gotten over here to the left side, or vice versa. Okay? So you always listen to the lungs for equal breath sounds. And then the number two thing that you are going to have to do is to order a chest x-ray. There has got to be a chest x-ray to ensure that the endotracheal tube is in the right place. So those are the important nursing interventions whenever a patient has just been intubated. Now, the other thing are things that are related to the ventilator. So I know that you probably have not undergone much training as far as ventilators are concerned, but a mechanical ventilator is going to be a machine that is going to deliver air to a patient, okay? And there are several controls that we have on a ventilator. One of those controls is what is known as the rate. And the rate is the number of breaths that the ventilator is going to ensure, right? The other thing that is going to be a control as far as a ventilator is concerned is what is known as the tidal volume. So the tidal volume is the amount of air that's going to be delivered into the lungs. Like, for example, if I measured the volume that resulted into the inflation of this balloon, that is what is known as the tidal volume. And usually the tidal volume is going to be set usually at around, normally we have the tidal volume at around 10 mLs per kilogram of body weight. So what that means is that if I am a 70-kilogram patient, my tidal volume normally would be around 700 mLs. But we do not want to give that much to these patients because we do not want to overinflate the alveoli because of the possibility that it might rupture the alveoli. So we kind of sort of lower the threshold. So the amount of tidal volume that we might give to a patient might be less. And so it might be around, let's say, 6 mLs per kilogram of body weight. Okay, 5 to 6. So in this particular instance, if the patient is 70 kilos, we might just start with 350 mLs. So that's the tidal volume, okay? And the other thing that is going to be a setting in the ventilator is what is known as PEEP, positive and expiratory pressure. So what is PEEP? All right, I already explained that earlier, and that is what is known as physiologic PEEP, meaning that the alveoli, when you inhale, expands, when you exhale, remains expanded. It deflates partially because of the presence of nitrogen. This is what is known as physiologic PEEP or normal PEEP. In other words, we do not have to do anything in order to attain a positive and expiratory pressure. Now, in patients who have ARDS, what we want to do is to prolong the expansion of this alveoli, because the longer the alveoli are expanded, the more oxygen and carbon dioxide can exchange. So there's going to be longer times of oxygen and carbon dioxide to exchange. And that is why in patients with ARDS, we add a setting known as mechanical PEEP. So we say mechanical PEEP to differentiate that with the physiologic PEEP. And we could apply as much as 5 to 24 centimeters of PEEP to these patients. Okay, so PEEP is set at increments of 3 to 5 millimeters of water until oxygenation is adequate. So again, what is the purpose of PEEP? PEEP prolongs the exchange of oxygen and carbon dioxide. But there's one thing that's very common in Nclex. Whenever they talk about PEEP, and they are the complications that are associated with PEEP. So what are the complications associated with PEEP? Number one, if you prolong the expansion of the alveoli, you could rupture the alveoli. And this is what is known as barotrauma. And this would result in pneumothorax. So we always have to observe the patient for signs and symptoms of pneumothorax. And the second thing that is a complication of PEEP is hypotension. So why is it that patients with PEEP will develop hypotension? So if this were the lungs, the heart is usually sandwiched between the two lungs. Now, if you overinflate the lungs, what's going to happen to the heart? So if we overinflate the lungs, what happened to the heart? It decreases in its ability to relax, and therefore there will be a decrease in cardiac output. This is the reason why patients who have PEEP will have hypotension. Okay, I stopped there to see if you have any questions. This two complications associated with PEEP is a common question in Nclex. So please remember these two. Any questions?
I have another question.
Sure.
Yes. Okay, so basically with PEEP, they're either gonna like if you're not adjusting it correctly and you give the patient too much PEEP, then it could lead to barotrauma and a pneumothorax. It's not like it's like a common complication after having a patient on PEEP.
Yeah, it's a common complication on PEEP, and that's why we do it gradually. And why do we do PEEP? Why can't we just increase the fraction of inspired oxygen? Okay, so FiO2 is another term that is going to be one control in the ventilator. It's called fraction of inspired oxygen. Okay. So when a patient is, let's say the patient has an O2 saturation of 70, this is bad, right? Is it bad? Yes, it is.
Yes.
Okay.
Yes.
So we want to give oxygen, right? So do you want to give oxygen at 100%? Do you remember what I said about giving oxygen at 100%? Anytime you give oxygen at 60% and over, you're going to have washing out of nitrogen. So the reason, therefore, that we give PEEP is that we do not want to do this. So rather than giving an oxygen of 60%, 70%, we'd rather increase the amount of time that the oxygen is going to be absorbed by giving PEEP. So do you understand? PEEP is an alternative to giving a lot of oxygen. So when we give PEEP, we could decrease the amount of FiO2. So the patient might be on 30% or 40% or 50%. We don't want to go to close to 60% or over because of the washout that occurs. Is that understood?
Yes.
All right. So the purpose of PEEP is so that we do not increase the amount of oxygen that we're giving. So whenever a patient has low O2 levels, we usually are not going to start them on oxygen aggressively. So we give as less amount of oxygen that we can. And if necessary, we're going to add mechanical PEEP. Okay? So that is exactly what we're seeing over on this slide, is that we're going to have a FiO2 that is going to be between 50 to 60%. We don't want to go beyond that. So rather than going beyond that, we're going to have a PEEP added up to 24 centimeters of water. Okay? Now, the other thing that we want to do is we don't want to force air too much into the lungs. This is what's called plateau pressures. So imagine that this was the alveoli, and I blow it with little force. Compare that now to blowing it with a lot of force. There's a danger of barotrauma. So we limit the plateau pressures, the amount of push that the ventilator gives, to around 30 centimeters of water. And lastly, our goal is to maintain a tidal volume of 4 to 8 milliliters per kilogram of body weight, and a respiratory rate up to 35, and an O2 saturation up to 95%. So you might stop me and say, Dr. Tom, why is it that the respiratory rate is going to be very high? You're saying that we want a goal of a respiratory rate up to 35. Isn't that a very fast heart rate? Well, the ventilatory respiratory rate is set at a higher rate in patients with ARDS for several important reasons. One is going to be to maintain adequate oxygenation, and also to decrease the carbon dioxide levels. So ARDS patients often have elevated levels of carbon dioxide. So when you increase the respiratory rate, it helps to remove the excess carbon dioxide. And by having a faster respiratory rate with lesser volumes, you're going to decrease the possibility of a pneumothorax. All right, so it's also imperative that we are not going to wean the patient right away. I mean, we have to establish or wean the patient from the ventilator through protocols. And there are several protocols that are going to be necessary, and we will talk about that when we talk about sedation. But the other P, as far as management of patients with ARDS, is positioning. It has been found out that prone positioning is going to be very beneficial in patients with acute respiratory distress syndrome. The explanation why this is, evidence have shown that prone positioning is going to improve ventilation perfusion ratio is because the heart is out of the way. So let me just explain that particular concept. So let's say that you are lying down supine right here, and the lungs are going to be over here, but on top of the lungs is going to be the heart. Thus, because of the weight of the heart, the ventilation and the perfusion in these areas over the heart is going to be less. But notice this illustration now. If I put the patient prone, the lungs are going to be unimpeded. They can expand and therefore they can ventilate fully and thus will improve oxygenation. So that's the reason why the patient is going to have a better ventilation perfusion when they are in a prone position. In addition to that, it also enhances the effect of PEEP, or positive and expiratory pressure. Now, there are some situations wherein the patient with ARDS is going to have difficulties with oxygenation despite all measures that we're doing. And so one other intervention might be ECMO, which is extracorporeal membrane oxygenation. And what is this? Well, we insert a catheter on a vein and then also on another vein. So we take out the blood from this vein and we're going to put it into an oxygenator, meaning to say that this machine is going to push oxygen into that blood. And then, of course, once it passes through that blood, to that oxygenator, we therefore return that blood again to the body. So that is ECMO. So ECMO can provide respiratory or cardiorespiratory support for failing lungs, for failing heart, or both. And this is going to be one that was very common, actually, that we use during the pandemic, COVID pandemic. All right. So let's have a question again. All right, so the classic finding found in ARDS is going to be a whiteout infiltrates bilaterally. So you remember, as I said, it's all white out, so letter C is the correct response. Okay, so let's see. Now, whenever you have ABGs, you're going to have to evaluate the pH as well as the PCO2 and the bicarb in order to determine what the condition is. So we begin with normal pH. We know that normal pH is 7.35 to 7.45. and anything that is less than 7.35 is acidosis, and anything that is above 7.45 is going to be alkalosis. Now, the other value that we need to evaluate is the PCO2, and normal PCO2 is anywhere from 35 to 45. If it is greater than 45, then this is acidosis. And if it's less than 35, this leads to alkalosis. And for bicarb, the normal is 22 to 26. If it is going to be less than 22, it's going to be acidosis. And if it's above 26, it's alkalosis. Okay. So the question asks, the patient with ARDS is ordered ABGs, which is expected during the early phase correlating with the diagnosis. So you remember that the early phase is going to be characterized by tachypnea. And therefore, if there is tachypnea, what happens to the carbon dioxide levels? The CO2 is going to be low. Okay, so in looking at this value then, this is low, the CO2 of 30, 37 is normal, 48 is high, and 58 is high as well. So immediately we're clued to the possibility that this might be the correct answer. And then the other thing is that if we look at the pH, 7.59 is alkalosis, 7.42 is normal, 7.20 is acidosis, 7.26 is going to be acidosis. So the correct answer here is letter A. Are there any questions as far as this particular slide is concerned? If you have problems or are weak in ABG interpretation, I encourage you to go back to go to my YouTube channel, because I have a very, very good video on a quick way to interpret arterial blood gases. Okay? All right, let's go to the next question. Okay, so if you are going to have a patient with prone positioning, then they should have improvement in lung sounds. So letter A is going to be correct, and as well as a PaO2 that would increase. So A and C are the correct responses. Okay. So in summary, as far as the treatment of ARDS is concerned, the treatment includes treating the cause of the ARDS. So if it was pneumonia or if it was sepsis, then that has got to be dealt with. The 5 Ps, which we have talked about: perfusion, position, protective lung ventilation, protocol weaning, and preventing complications. So what are some of the measures to prevent complications before we go to the drugs? Well, the complications that are going to be very common in patients with ARDS includes DVT. So how or what interventions are going to be necessary for DVT? Well, making sure that we have this sequential compression devices in order to prevent embolic phenomenon, as well as thromboembolic stockings should always be started on admission. Pressure ulcers is also going to be another challenge because of poor tissue perfusion and limited movement, as well as poor nutrition. And lastly, because they're going to be on a ventilator, they might develop ventilator-associated pneumonia, which we will be discussing next. However, I'd like to go back to some of the medications that might be useful in the management of patients with ARDS. And they would include your steroids, your low molecular weight heparin, in order to prevent thromboembolic phenomena, enteral nutrition, and stress ulcer prophylaxis. Whenever patients are under physiologic stress, we usually give medications that includes your proton pump inhibitors. So what are your proton pump inhibitors? They're the same drugs that prevents ulcer or treats ulcer. So they usually are going to end with the suffix prazole. An example of that would be omeprazole, esomeprazole, pantoprazole. All those things are going to be proton pump inhibitors. There's also a possibility of nitric oxide being inhaled by the patient in order to, again, replace the nitrogen that has been washed off. And in some instances, when patients are going to be restless and fighting off the ventilator, we not only sedate them, but sometimes in order to maximize the benefits of a ventilator, we might have to paralyze the patient. So it's not unusual for patients who are on ventilators to be having a propofol drip, for example, or Versed or morphine at regular intervals. And in addition to that, we might have a paralytic agents like pancromium bromide to totally control the patient so that we can ventilate them properly. Okay, so the other complication that is going to be necessary is what is called the ventilator-associated pneumonia. And so what are some of the measures in order to prevent ventilator-associated pneumonia? Well, they include the head of the bed elevation. And what is the recommendation as far as the head of the bed is concerned? Well, the head of the bed is going to be much more effective if they are going to be at around 35 to 45-degree angle. In addition to that, there has got to be oral care with chlorhexidine. So the oral cares of patients who are going to be on a ventilator includes the following. Okay, so we assess the oral cavity and lips every 8 hours. And we perform oral care every 2 to 4 hours. And when we say oral care, what does that mean? That means to say that we're going to brush the patient with a toothbrush at least twice a day. And of course, we're going to use a cleansing solution that assists in the breakdown of debris, such as sodium bicarbonate or hydrogen peroxide. And then in a daily schedule, there has got to be a chlorhexidine that is going to be applied as an oral care in order to decrease the incidence of ventilator-associated pneumonia. So that's the oral care, which is very important. Stress ulcer prophylaxis, and we do not want the patient to be sleeping all the time, and therefore it is recommended that we assess the patient and as much as possible, take them out from sedation as early as possible. And then, of course, your DVT prophylaxis. So that ends my presentation on ARDS. And so what we go now is, or what we're going to do now is to go to the case study. And I hope that you had the opportunity to answer the case study. If you did not have the opportunity to do so, I would encourage you to have that or to answer it so that you could review whether or not you understood this particular presentation. And so I'm going to indicate in the chat box the link again to that case study. Okay? Oops, what happened to this one? All right. So the nurse cares for a 78-year-old female admitted to the medical intensive care unit in respiratory distress. The client was admitted to the ICU in respiratory distress after minimal response to high-flow oxygen for a pulse oximeter reading of 83% on room air. Crackles heard bilaterally in the lower lobes with diminished breath sounds in the right middle lobe, S1, S2 auscultated, bowel sounds ×4 quads, skin warm and dry, intact, vitals 99.8, 110 heart rate, 30 respiratory rate, blood pressure 168/90, pulse ox 87 on 100% non-rebreathing, and pain is 0/10. Okay, so the lab reports are displayed, and we're going to still display that, but there's now a question. Which 4 findings are most urgent? All right, would you please put in the chat box the 4 findings that you think are most urgent? All right, how about the others? Thank you, Latoya. Thank you, Sheyang. I understand the others might be using a phone and they might not be able to totally answer the question. So I'm just going to wait for a few more responses. All right, thank you, everyone. So when you are looking at this question, and from now on, when you're looking at a question similar to this, because you're going to have 3 case studies, you remember, and the first question is going to ask you which ones are going to require you to act or are most urgent. You always have to think about your test-taking strategies. And one of those test-taking strategies that I want to emphasize is always remember that the urgency or the things that you need to address first follows your hierarchy of needs. So the first one is going to be ABC. So airway and breathing is much more important than circulation. And then the other one is, of course, physiologic needs are going to be more urgent than your psychosocial needs. Okay? So when we take a look at this, a blood pressure of 168/90 is not good. So we're just going to just check it a little bit. The WBC is 35,000. So this is going to be also a concern. A lactate of 4.5 is also a concern because, as you could see, 4.5, the normal is 0.5 to 2.2. A pH of 7.2 is also bad because it is going to be acidosis. And a CO2 of 50 is also bad because this is acidosis. A PO2 of 75 is also bad because, again, this is hypoxemic. But it's not really that bad because normal PO2 is, as you could see over here, 75 to 100 in this laboratory. So this is okay. But the respiratory rate of 30 is going to be high, and gram-negative cocci and a pulse oximetry of 87. And again, a pulse oximetry finding of 87 is going to be low, right? So when we're taking a look at this, there's one prevailing common finding that we see, and they are all things that relate to airway and breathing. So if we are going to look at those things that are related to airway and breathing, letter E is going to have to be chosen. And letter G has got to be selected as well. And letter I has got to be selected as well. So CO2 of 50, a respiratory rate of 30, a pulse oximeter of 87. And the other thing that's related is this one. This is acidosis. So they're all related to airway and breathing. So D, E, G, and I are the ones that are going to be the most important. All right. So the good thing about Nclex is that if it asks you to choose 4 findings and you are going to have 3 errors, you are going to be scored 1. Okay. So which means to say that you're going to only be corrected or given points for those items that you selected correctly. Okay, so please remember that whenever you're looking at a question for the first question on the case study, you now try to remember that the selection of the most urgent or most important things are based on the hierarchy of needs, including airway, breathing, circulation, as well as physiologic is more important than psychologic or psychosocial issues. Okay, so let's go to question 2. For each finding, choose to indicate if it is consistent with acute respiratory failure or pneumonia. Each finding may support more than one condition. Each column must have at least one option selected. Okay. Crackles in the bilateral lobes. Do you see this in ARDS? Acute respiratory failure. Yes or no? Can you please indicate in the chat box? Yes, this is going to be yes. Remember that there's going to be collection of fluid in the interstitial spaces, and therefore it would cause crepitations or crackles. Now, is this a finding also that you will find in pneumonia? In pneumonia, do you have crackles? In pneumonia, do you have crackles? Yes. Okay, very good. Yes, so we would check that. A pulse oximetry of 87 on 100%, which means to say refractory hypoxemia. Is this going to be something that you will see in patients with acute respiratory failure? And the answer to that is yes, and also in pneumonia. Now, the finding of a pH of, a CO2 of 51 and a pH of 7.2 is going to be very, very critical. And therefore, these are things that you will find in acute respiratory failure, but not necessarily in pneumonia. Okay? because this is very severe. A PaCO2 of 51 and a pH of 7.2 indicates respiratory acidosis and are going to be much more associated with acute respiratory failure. Okay, let's go to the next question. So, what does the nurse determine is the priority for this client's care? So you know that the patient was having a pulse oximetry of 87% with a respirations of 30. Should we give steroids? Should we intubate? Should we open with bronchodilators, or should we treat the infection? Which one do you think is the most critical and the priority for this patient? A, B, C, or D? I agree with you. Letter B is going to be something that buys a mechanical ventilation, right? Because the patient is in respiratory failure. I'd also like for you to remember the 50-50 rule. And 50-50 rule is a manifestation of acute respiratory distress. And what is the 50-50 rule? Whenever you have a PO2 of 50 and a PCO2 of 50 or more, this is an indication that the patient is in respiratory distress, and therefore they have to be mechanically ventilated. Okay? So letter B is the correct response. So let's now go to the next question. And this is a new note at 9:30. So at 9:30, the client was intubated with a number 6 endotracheal tube and was placed on assist-controlled mechanical ventilation with a rate of 14, a PEEP of 5, FiO2 of 60, and the vital signs are as follows. Okay? So, question number 4 asks you now, the nurse plans for the client after beginning mechanical ventilation. For each potential intervention, click to specify whether the intervention is indicated or not indicated to include in the plan of care. All right. Sedatives. Is it indicated or not indicated? Just say I or NI. Sedatives. Okay, very good. Obviously, if a patient is on a ventilator, you want to control the respiratory efforts, and therefore you need to make sure that you either sedate them or paralyze them or both. Okay, how about schedule suctioning every 2 hours? Indicated or not indicated? I or NI? Very good. You never have routine suctioning. Suctioning should always be a PRN intervention. And the reason is every time you suction, you not only suction secretions, but you're also suctioning oxygen. And therefore, it is going to have a physiologic stress on that patient. So that would not be indicated. How about letter C, administer amiodarone? I or NI? Okay, so amiodarone means to say that this is an antiarrhythmic agent. Anytime you see arone, this is an antiarrhythmic agent. There is no mention at all over here that the patient is having any arrhythmia, and therefore this is not indicated. All right. How about administer antibiotics? I or NI? Yes, look at the WBC. So this is indicated. And how about supine with the head midline? Letter E, I or NI? Letter E, I or NI? All right. So you do not want the patient supine. You remember 35 to 45-degree bed angle or prone position for this patient. And obtain an electrocardiogram. Now, if a patient is serious, do you need to connect them to an electrocardiogram? The answer to that is yes. So it is indicated. Very good. Okay, let's go now to question number 5. The nurse receives orders. Choose the 3 orders the nurse should implement first. Could you please give me your idea of what 3 orders should you implement first? Which one you would you implement first? B, as far as medications or monitoring? Yes. Okay, very good, Latoya. She remembered that very well. Remember, the patient was just intubated, and therefore you need to call for a chest x-ray. Very good. All right. Now, the client does not have any venous access. And so, in order for you to give medications, you have to have an IV. So, the next thing that you're going to have is you're going to start an IV of 9% normal saline at 75 cc's per hour. Okay. And the last one, remember the patient has just been intubated. What did we say? We need to control the ventilation of the patient, and so we need to sedate them. So these are the orders that would need to be done right away. Okay? And let's go to the last one. So on the last one, we're going to evaluate whether or not the patient has improved, declined, or unchanged. So we are looking at the 10 o'clock notes and the 9:30 notes. Okay, so the heart rate at 9:30 was 110, and now it becomes right over here 100. So is this improved, or is this declined, or unchanged? Improved. Okay, good. The temperature at 9:30 was 99.8, and the temperature at 10 o'clock was the same, 99.8. So is this improved, declined, or unchanged? Very good, unchanged. The respiratory rate over here was 14 at 9:30, and now it is going to be 14 at 10 o'clock. So is this improved, declined, or unchanged? All right, unchanged. The blood pressure on 9:30 was 180 over 90, and now it is going to be 150 over 70. So is that improved, declined, or unchanged? Improve. Okay. So that means to say that patient is not as stressed as before. And the pulse oximetry was 96 at 9:30, and now it is 93%. Declined. Okay. And the agitation, the client is restless, and now the patient is on a minus sedation scale, meaning to say that he's drowsy. So that's the Richmond agitation scale. When it says minus, that means to say that the patient is sedated. So that means to say that it is now improved. Okay, great. And that ends my presentation. And I hope that you had the opportunity to be reviewed as far as the important things related to sepsis and ARDS is concerned. I want to thank you for your participation. I hope that you attend again tomorrow. And as always, I want to welcome any questions that you will have. All right? So thank you, everyone, and please come back tomorrow. Thank you, Latoya.
Hi, can you go back to slides before, please?
Which one? Which slide?